Welcome, guys. Welcome, guys. Episode 5. I can't believe we're here. And here's Danielle Doyle.
Hi, Diego Davis. Thank you so much. We have an exciting guest that's coming on today. Her name is Kate McLaughlin. I'm sure if you're a nurse, you know this name. She's absolutely amazing. She's leader of New Jersey Safe Ratios. Absolutely wonderful. She's an advocate for nurses and safe staffing throughout New Jersey and throughout the country. You're really going to want to hear what she has to say all about, what's been going on during the COVID-19 crisis, everything that led her up to her position currently, and where she sees the future of nursing going. And more importantly, our big issue right now, which is protecting our nurses and our PPE issue that we have. So we'll be bringing her in right now. Don't forget to subscribe to our channel, hit the like button, hit the little bell, and subscribe to SeeUNextTuesday. You're going to want to get notifications. Pretty soon we're going to be coming on live, so you're not going to want to miss that. This is our 5th episode, like Diego said, but as we get moving, we're going to be live on here, so you'll be able to check us out and comment and interact. But either way, if you comment in the section below, you can ask us questions. You can ask Kate some questions. She'd be more than happy to answer you and reach out and get to chatting.
Yeah, Kate McLaughlin. Also, too, before we get her back on, I just kind of boost her up, just remind the people that she's going to be, I think she's speaking in D.C. this year at Nurses Take D.C., which she spoke last year, actually. It was an amazing speech. An amazing nurse, amazing person. So looking forward to it, really.
Yeah, definitely. Let's welcome Kate on in.
What's up, Kate?
Hey,
how you doing?
How are you? I'm good. How are you?
Nice to see you. Nice to see you.
You too.
I keep, I always talk about where you live, but I'm always astonished about your background, your scenery. What part of Jersey are you at?
I'm in Medford, New Jersey. So I'm in, I did not know that we have like the land of like the hundreds of lakes in New Jersey. And I have to say, for someone who went to a nursing program at UMDNJ, now no longer existent, but in South Jersey, I did not realize this beautiful area, but literally South Jersey has hundreds of lakes. I live in a lake community.
Oh my God.
Listen, I'm a critical care nurse. You know, you got a lot of stress. My goal was when I was house hunting, I went somewhere when I go home from work, I can go and I can literally relax. So
yeah, I'm decompressing just watching your background right now. I'm just really, that's
here you
amazing.
go. I'll give you the, ooh, yeah, no, I was really, really fortunate and got really lucky.
Oh my God. Well, just wanted to talk about, bring you on because, you know, this segment is basically about like inspirational people. And like I've talked with you in the past several times, and I just think what you've done for the nursing career, especially in New Jersey, is amazing. Just tell us a little bit about your career. What to this point, like what are you doing now?
Well, my background has always been healthcare. I literally started off as an EMT at like 16 years old. I went in the military, spent 7 years as a medic, then I was a flight medic. Got out and said, I'm done with healthcare. I thought I wanted to be a high school science teacher. And then I went back and got a second degree in nursing and have been a nurse in New Jersey for well over a decade. My whole background has been emergency medicine, trauma, and critical care. I spent most of my time up until about 2 years ago in hospitals, but now I do critical care transport, which I really, truly do love. In addition to healthcare, I run and founded New Jersey Safe Ratios, which is a patient and nurse advocacy organization that looks to improve patient outcomes and safety amongst our patients, but also to improve nursing as a career path for us and also our safety, especially with all the stuff we've seen with the lack of PPE. So I deal with legislators on a regular basis and trying to get folks to understand the challenges that we see on both the patient side, but also the nursing side.
Yeah, that's amazing. Because I mean, it's all about patient safety and as well the nurse safety as well. You know,
right.
We saw a lot of people getting sick with the COVID-19. Danielle, did you have questions about the PPE you were asking about? You were going to ask Kate.
Yeah, well, I was wondering, you said the challenges that we were having. Can you explain a little bit more about, because for the regular person who just thinks nurses go to work and everything's all good, what kind of challenges have you seen in the industry? I personally left staffing for that reason, so I want to see if we have the same views.
Well, I think one of the things that we saw, especially and that we're seeing and continuing to see and evolve, especially with COVID-19, is there's a trifecta. We've always had issues with a lack of staffing, which has been from nursing homes, long-term care, group homes, mental health facilities, where there's a lack of staff, nurses, nursing assistants, aides, you name it. And that is one problem. The other problem is that we've had issues with lack of safety, lack of this PPE. And for people that don't understand what that is, it's your personal protective equipment. And for years, we've relied on systems of having a mask that an organization would buy. So maybe it's the coveted 3M N95 mask, but an organization might buy thousands of these masks that are supposed to be single use. You use it once in a room and then it's discarded because it's really not safe to put this thing that's in an infectious room back on your face.
I like where you're headed with that, because I was more concentrated on I think we talked before in the past about the monopoly of a hospital, not even worried about people's safety anymore. You know what I'm saying? We're just, that's where we're headed. Yeah. And if you're going to get paid like we're talking, that's why I think we have a lot of more options as nurses. But go ahead, I'm sorry.
The challenges we face, especially with PPE, people not knowing what PPE is, right? When COVID first hit, there was medical staff outside holding signs, we need PPE. There were hashtags, get us PPE. And that's kind of dwindled. The issue is, unfortunately, is that the PPE, personal protective equipment, the masks, the N95, the coveted 3M masks that hospitals would purchase, maybe that was the only type of mask that they purchased for their entire staff. Well, if you look at our faces, my face is different than your face. My face is not maybe going to fit into a mask appropriately and give me a great seal. Maybe I need a different type of system. These hospitals didn't necessarily purchase the equipment they needed for staff that did not have the ability to use this one type of mask, the N95 by 3M. And we had these nurses who were being exposed. So there's another system called a PAPR. It's a hood with an actual air generating system and a filter, and they're expensive. When I worked up north at a level 1 trauma center, we had some, but we didn't have enough for everybody. What I learned from talking to nurses was that instead of those hospital systems purchasing these alternative PPE masks for the staff, they chose not to because it's expensive. So these nurses, during a time when we have a shortage of nurses because we've always had a shortage of nurses, but B, we have a shortage of nurses at the bedside because we had an onslaught of really sick people requiring especially critical care. We had nurses who did not or were not able to use those masks, those N95s, that were furloughed because their hospital systems did not invest in a protective mechanism for them. They furloughed them. And that meant that we lost really highly skilled veteran nurses due to financial issues of hospitals not wanting to provide what was needed. So you had situations where with our organization, we pulled nurses from every hospital in New Jersey. Some ICU nurses had 5-6 patients each. These people are sick. They're on ventilators. Other nurses were told, just use a surgical mask. It's fine to go in the room. They're on a ventilator. And we know from the research out of China and Italy and Germany that just wasn't true. In New Jersey alone, I mean, we had several nurses getting sick. And it was unfortunate because COVID isn't just like a cold and it passes. Some of these people wind up with lung fibrosis and they don't go back to where they were before COVID. So, we definitely, as an organization, have been working diligently to inform and really enlighten our legislators. Some of them have wondered well, how did they not have protective equipment? Well, as we know, we had supply chain issues was one issue, but the larger issue is over the years, if healthcare systems were not investing in this protective equipment, even gowns, how do you expect to protect those nurses? So I know that for myself, I'm very fortunate. Like I said, I'm not in a healthcare system, but my bosses recognize the issue. We're a small business and they struggled to get enough N95s for everybody. But they also allowed us, they said, listen, if you find a CDC FDA approved respirator for yourself with the cartridges, yes, we'll fit test you and you can use that. Well, I'm fortunate. We transported almost 1,500 COVID patients in the last 3 months. Not one person got sick from my company, but not one person was ever denied the ability to wear a protective mask. My colleagues in hospitals, we had a nurse in Voorhees who was fired for bringing in an N95 mask. We had nurses in Beth Israel and Newark who were suspended for fundraising for PPE. Nurses in many hospitals around the state that when they tried to bring in their own PPE, they were told they couldn't wear it. That got us involved with legislators like Senator O'Scanlan to go to the Hospital Association and to ask them to please have their hospitals and long-term care facilities to please stop threatening nurses. We were fortunate that JACO, the CDC, the FDA, and even several doctor-physician groups said, please, we're asking you to allow people to use the alternatively approved reusable PPE like the respirators. So.
Right. Do you think it was more politics, or just it's just so strange that they wouldn't let you use equipment that was available to you to protect your life?
I think part of it, it's a multifocal issue. So one is like, if I bring a mask in, the hospital can say, their attorneys are probably saying to them, well, if they bring a mask in and they get exposed, then, where's the liability? Well, if you're asking me to reuse an N95 that you may or may not be cleaning once a week, or after you're making me use for 3 weeks, the integrity of these masks, as we know from research, breaks down. So why not allow me to use something? Well, that comes into the political thing. The CDC approved this extended use. They also approved and supported the UV light process, the hydrogen peroxide process of cleaning these masks. And for some reason, the hospital associations and the hospitals' employers, maybe it's because they felt like if a group of people, perhaps physicians, has access to P100 masks, which are reusable with the cartridges, but the nurses don't, that may set up a tribalism. Well, from what I've seen at my former employer, many of the physician groups purchased their own PPE for their doctors, but the nurses were left utilizing whatever the hospital gave them and was refusing to even let them use the reusable sources like the approved list from like the CDC, like the P100 masks or the gas masks. So I'm sure there's, and I like I said, I've had discussions with legislators about this, and they didn't understand, like, well, why aren't all hospitals doing this? It's expensive. Yeah. A mask, an N95 before COVID cost less than $2 a mask. Now it's like $5 a mask. But if I have to,
that's crazy, right? Yeah.
And if I have to outfit everybody with, let's say, a 3M, an MSA, or any of the approved PPE that's like a half-face gas mask or a PAPR, you're looking at maybe $30 for the mask, $20 for a set of cartridges, or a PAPR, you're upwards of $600 or more. So it probably was an issue with cost containment. So, that's where things have to shift. We need to ensure that people have the appropriate PPE and make sure that every time they go into a room, it's that they're safe. There's no reason that a nurse should be put at harm's way. And one of the things we had seen, and I was very thankful to ProPublica, Marshall Allen's a fantastic investigative journalist. He worked with us in really exploring and enlightening people and producing a fabulous story about nurses who were being threatened around the country, and especially here in New Jersey, about PPE, even to the point where nurses who felt they weren't protected, they resigned. They resigned from their jobs, not abandoned their patients, but even resigned from home, and their hospitals threatened them with having their license taken away. So we're seeing that we need people to advocate for us. That's where nurses like myself and our organization comes in. Laura Gasparis comes into play, really making sure that we as the bedside nurses have a say and have a voice.
It's amazing.
Yeah, definitely. We had a couple of nurses that were, just like you said, they were canceled from their contracts for wanting to wear their own PPE. I think it has a lot to do with the politics of the hospital systems and the way that it's moved from, you know, a family-friendly organization into more political. And also a lot of the places are, they're cookie cutter, one size fits all, everybody has to be the same. So if an agency nurse comes in wearing a mask and a hazmat suit and their staff don't have it, it just creates issues for them. I just don't get why safety is not the number one priority. It's less cost for them to let the nurses just bring their own PPE. So we really need to figure out and get to the core of where the cause of this is coming from.
I think though, like I'm just thinking from a business perspective. I'm thinking, you know, just from my own business mind, that possibly being a little devil's advocate for the hospital, just like Kate was saying, if they get sick, they can't blame, you know, they're going to blame their equipment that they bought in. So,
Why not
you know,
sign a waiver then?
Exactly.
yeah, waiver that'd be good. Yeah. You women
Yeah,
always think fast.
I agree with the waiver, and this is like one of the things too. Throughout the United States, I think the figure as of May, we had over 600 healthcare providers that died of COVID, and a lot of them were exposures. And even looking and listening to the reports that have come out and following what's happening in our own state, we had, as of May 20th, there were over 5,400 deaths in long-term care facilities. One of the biggest issues we saw in long-term care facilities, and well, it's multifocal. Like I said, you have the lack of staff, okay, lack of resources, and then you had a lack of PPE. We did not do infection control in nursing homes well before. I mean, if you remember the WannaQ deaths, we had several children die in a long-term care facility, and that was from an enterovirus, I believe. You know, the infection control measures weren't there. You don't have enough staff. We know from research that's been published, peer-reviewed, less staff means more infectious outbreaks. That's a given. It's not anecdotal. This is legitimately been researched. It's been published. It's been peer-reviewed. Study has been able to be redone in another area, found the same thing. Now, we didn't learn from WannaQ in New Jersey that the staffing was an issue. We didn't learn in WannaQ that staff should have been wearing face masks so that, and people who were sick were not passing it along. When COVID happened, you know, there was an issue with a lack of PPE. You can blame the federal government for that. You can blame, and you can blame the state. There's enough blame to go around, even down to the independent hospitals who never purchased the appropriate PPE for their staff to begin with. You know, like I said, nurses who worked for 15 years at a hospital were furloughed because they could not pass a fit test for the mask the hospital bought. The hospital never went and bought them a different type of mask. The other issue was in long-term care facilities, I heard from nursing assistants and nurses that they were being told that if they wore a simple surgical mask, they would be fired. Now, it doesn't take a genius to figure out that if you have an infection that is droplet, right, that at least a simple barrier like a face mask would at least help reduce transmission rates. But unfortunately, they were no longer allowed to wear them. In hospitals, I think it was Banner System down in Arizona, a nurse who did not get a flu shot, and she was not the only nurse, this happens nationally, but when you do not get a flu shot, the hospitals often require you wear a surgical mask through flu season. Very common. Some people can't get a mask, they have religious reasons, others have allergies, what have you, or immunodeficiency, immunocompensation, whatever the reason. But the policies have always been, if you don't get the flu shot during flu season, now COVID season, you wear the surgical mask. This nurse went into work with a surgical mask and she was told she could no longer wear it and that the hospital changed the policy, the flu policy, that she no longer could wear a surgical mask. And she was terminated for that. And it, like I said, this was happening everywhere. Now, was it because of supply and demand? This nurse had her own supply, as do many nurses who choose not to get a flu shot. Why would you change the level of infection control that would potentially protect someone from getting the flu as she had it? Why change that measure? And again, it goes back to what Danielle was saying, potentially with these employers not being able to provide something for everybody. But there was a complete lack of common sense that went out the window. In our own state in New Jersey, I myself, as a nurse, I've dealt with infectious patients. In the military, I worked on a unit that dealt with one of the first outbreaks of VRE back in the day.
Wow.
Our infection control back then, when you came in, we were not allowed to wear scrubs. You had to wear camouflage uniform or horrible polyester military nursing whites. And when we got VRE that broke out, and this was early 90s, nobody knew what it was. We would have to change into scrubs. We had to wear sneakers. We didn't wear sneakers at work in the military. You wore combat boots or horrible nursemaid shoes. They were awful. But you were allowed to wear sneakers. Those sneakers were not allowed to leave the infectious area that we had segregated as the back of our unit. You were not allowed to go to the chow hall or dining room. Like, people could bring you food, but you were not allowed to go into the break room. We were very strict. Over the years, things have changed with infection control. Now, if you have visitors and you have C. diff, they can choose to wear or not wear the PPE. But then you see them in the line stealing French fries at the cafeteria.
Yeah, that is so strange. I've seen that.
Right. So you go back to nursing homes where there's not a great investment in A, education, B, staffing, C, PPE, and now you have a soup. You have the perfect storm for an outbreak. There's also a lack of taking these people who are getting discharged from hospitals, because not every person who got diagnosed with COVID went to the hospital and died. They eventually were going to leave. And instead of setting up specific nursing homes that were going to be isolation nursing homes on a regional basis, maybe in Bergen County, you had 1 or 2 facilities that could have been converted. That didn't happen. And it probably didn't happen because of customer service. We weren't thinking infection control. We didn't think about what would happen when one of these people comes back to a nursing home facility where your staff member, Sally, might have been working with COVID patients on Monday and Tuesday, but Wednesday, Thursday, and Friday, she now has non-COVID patients, and consequently didn't have the appropriate PPE. That's why over 5,400 people were dead by the time May hit.
That's crazy.
We have, and I think for most people, I think for the layperson, they don't understand the transmissibility of this, but we also perhaps did not do a very good job of telling people, hey, this is the challenges we face. This is what we need to do. And it got out of hand. That's why pretty much every nursing home in New Jersey, long-term care facility, had COVID patients. And why in some facilities, you had a majority of the staff that were sick or asymptomatic and transmitting.
So there is a question as to whether there will be a second wave or this is going to happen all again in the fall. What do you think nurses can do overall, and what are you doing to help prevent the same thing from happening again? How do you think we're going to be better prepared this time?
I hope that, I know for where I am with my company, they've used this time to really make sure they bulked up their N95s, but they also took it a step further. And again, I work for a small independent company, so we are not able to access the state stockpiles. But what they did do, because they realized if one of our staff gets this and there's 3 of us on a critical care ambulance, it's going to spread like wildfire. What they did is they purchased these reusable respirators, like the half-face gas mask. They purchased 1 for every employee, which was smart, because they're like, we'll get the cartridges as we need it. They made sure they ordered the N95s and that type of mask as well. But they really saw, if this second wave happens, their preparation was to purchase appropriate PPE. Now, for myself, I was in St. Lucia when Italy hit. I was on vacation. I was coming home from St. Lucia probably about the time we had the first patient in Washington State. What I had done is I was on vacation ordering PPE. So I had ordered my half-face gas mask and my cartridges. I had ordered a reusable helmet face shield. I ordered a Tyvek reusable suit. And I think for nurses, now is the time where you can maybe get this stuff. Get your own source of reusable PPE. And make sure you know how to use it. Ask your employers to fit test you. You can still be fit tested. There's 2 ways of fit testing through OSHA. One way is called the quantitative, and one is the qualitative. The quantitative measure is when you see them have a mask that usually has a porthole pushed in it and there's a measuring system, some sort of electronic measuring system that measures leak. The qualitative is when they put the hood over your head with the mask on and say, do you taste sweet or bitter? Well, the CDC halted the quantitative. They said, we don't need to know, we don't need to measure your fit test this way by destroying a mask. The qualitative with the hood, we can still do. You can do a test on anybody, any kind of mask qualitatively. So there should be, like, especially unions, negotiate, speak with your hospital groups, and even nurses in non-union facilities and CNAs. Come together and sign a letter that if you're able to get these gas masks or these respirators, that you should be tested to make sure you have a seal. On our end, we have sent a letter, and we worked with Senator O'Scanlan's office. I believe the letter went to all legislators demanding that they allow staff to use masks if they are of CDC, FDA approved. What we need the legislators to do is to make sure that there's an approved measure so that medical staff are not being essentially disciplined for that. So we're going to continue to work on that because I do believe we're going to see a second wave. They're already seeing it in Arizona, and probably the better place to look at this. I have many friends around the country who are nurses. When COVID hit, San Diego got hit hard the first time. San Diego's getting hit repetitively. San Diego is one of the first places that they started splitting ventilators, having 2 people on 1 ventilator. They're going to be in a spot because of migration that they're going to constantly be having a reintroduction. New Jersey, we're just opening up today. Our restaurants are opening up the 22nd. Our hairdressers, massage places, nail places are opening up. We are going to see a second wave. What's going to happen in the fall? Who knows? We have to be conscious ourselves as providers to be using appropriate PPE, hand washing, making sure you're wiping down your surfaces. Don't step back thinking this is gone. And I say that because as a nurse who's transporting these patients, you may not see it in your hospital system if you're really far South Jersey, especially like weeks ago where Bergen County was getting slammed. And I had a lot of medical staff that's like, oh, this is blown out of proportion until it migrated to their areas. Be vigilant. And again, really start working. We're going to put up a petition on the NJ Safe Ratios website probably by Friday that's going to ask to make sure that our legislators are supporting medical staff and making sure that they are allowed to use their own PPE if it is something that is approved, and that we're also asking that the hospitals do that fit testing and that those healthcare providers have the ability to have a fit test done.
It's amazing.
So get active, make sure that you're reaching out to legislators. We are going to make sure that within the next week or so through Facebook, we'll be doing mass phone calls to legislators again. We generally do them for staffing, but we're doing them for PPE right now because that's primarily the number one thing. We know the staffing is bad, but our shift right now is on PPE. As my medic instructor told me in the Air Force years ago, a dead medic is no medic. If a nurse is sick, they're going to pass it along to their colleagues, their families, and they get sick. And we don't want that happening. We don't want secondary casualties. We want to make sure the staff is protected. If the hospitals are unwilling to do it, then we need our legislators to push them to make it a regulation.
Well, that's my next question, though. You keep talking about legislators, and I know you had a voice in Nurses Take DC like last year. I think we spoke about it. I think you'd be a shoo-in for a run for something. I mean, you have a voice, you have a positive attitude, and you're just very inspirational. What do you think? What's going to happen with Kate McLaughlin in the future?
I think you're going to see Kate McLaughlin running for office, definitely state level, Assembly, Senate. I think what we need to do is to change kind of the paradigm that we have. Currently, our legislators, off the top of my head, knowing who these legislators are employed by, we have a state senator who was a former vice president for the Robert Wood Johnson Barnabas healthcare system. His wife is an executive leadership for Barnabas Robert Wood Johnson. We have another legislator who happens to be an executive as well for Hackensack Meridian. We have another senator who is on the board of directors for Encompass Health or Health South, which is a huge nursing home conglomerate. We have an assemblywoman who was a lobbyist in healthcare, but also represents the teaching hospitals of New Jersey. And many of these people sit on the healthcare committees that are deciding policy. I think what we need doctors and nurses on the front lines. We need CNAs. We need people who are involved in actual bedside care to get politically active and to run for office. Because when you, unfortunately, are at these executive level positions, I think that that's a maljustice to the people. We have, if you looked at the Senate Health Committee and the Assembly Health Committee, I could find you multiple people have conflicts of interest. We have senators married to executive leadership at hospital systems. Jefferson, like I said, Robert Johnson Barnabas, we have them in leadership positions for St. Francis Hospital. I mean, there at some points, we know that the healthcare systems, the executive leadership, they're not looking out for the patient per se. They're about generating money and hopefully good outcomes. But they've also been the organizations that have worked so hard against us for 17 years with safe staffing. And when we talk to legislators, I mean, some of these legislators, I've been pounding the pavement for 3 years, never had a meeting with them. There's a massive conflicts of interest. And we're saying, let's have a discussion. They're unwilling to do that. And I talk with presidents of unions. I have a very good relationship with HPAE. And, you know, there's the frustration of when are people going to start listening to the people at the bedside? I think only going to happen when we get involved in politically. So the first thing every nurse needs to do, you need to vote. Yeah. We have elections coming up. I will post information on how to vote by mail, how to register by mail. If you are not voting, now I don't care what party you vote for, just vote. And take the time to look at what's happening with policy. Generally before each election, I make sure I put out a list of how legislators voted in the past, what their policies are. Do they support healthcare? How are they supporting it? And I always ask people, I said, take the time, go to town hall meetings, ask questions, and stop voting in people who are not working in the best interest of you as a nurse, as a healthcare provider, or for patients. If they're not doing what we need them to do to improve patient outcomes, patient safety, and the work environment, then we need to get rid of them and replace them. So you may see me on a ballot, you may see me floating around a ballot somewhere in South Jersey next year, 2021.
I'm excited for you. Very powerful words. Thank you for coming on this week. Definitely. Thank you for being here. We love what you're doing, and just keep it up. Please keep us informed. Love to have you back.
That'd be great. Absolutely.
Yeah. Awesome. Let's stay connected. We're going to put in the comments below how to connect with you, where we can find you, and how our nurses and followers can connect with you in the future. Also, don't forget to subscribe to our channel. Hit like on the bottom. There's a little bell that you can hit to get updates when we go live and when we have new videos. And always remember, you need access to get in.
I'll see you next Tuesday.